Good morning and welcome to day 3 of Technology Association of Oregon's Digital Health Week. We're excited to continue conversations focused on healthcare technology with today's program, Innovation in Healthcare Delivery Models. I'm Riley O'Brien, VP of Events and Experiences with TAO, and I'm joined by Ruthie Ditzler, our Marketing and Regional Program Coordinator, who is providing back-end support on Zoom. A couple of rules of engagement before we get started. All participants have been muted. Please remain on mute until a TAO staff member unmutes you and calls on you to talk. You may ask or respond to questions in the chat box publicly or privately by directing your message to me or Ruthie, who is under the name of Special Events. We'll be monitoring the chat box and respond throughout the discussion. We also ask you all to use the engage via participant icon. You can give a thumbs up or clap your hands. Let us know if we're going too fast or too slow throughout the presentation. We invite you to engage with us on social media during this call and throughout the day. We love to share what's going on at TAO and get participant takeaways from our events. We invite you to join us tomorrow morning for a conversation on information blocking rule to find out if your organization is ready, and innovative healthcare delivery and broadband network infrastructure. A big thanks go out to our sponsors, Link Oregon, Otradi OBI, HIMSS Oregon, Israel Consulate General of the Pacific Northwest, and Ocean for underwriting our Digital Health Week. We really appreciate all of their support, and we're excited to explore all of these topics related to digital health. You can find all of these presentations on YouTube following the presentations. Usually they upload in the afternoon, and on our blog, you can find a breakdown of what happened over each of these days during Digital Health Week. And finally, it's my pleasure to introduce our moderator for this conversation, Senior Director of Collaborations and Entrepreneurship at OHSU, Aditi Martin. Aditi, take it from here.
Thank you, Riley. Good morning, everyone. Thank you for joining us today. And a big thank you to our panelists. Today we have with us Anil Kumar, founder of RxHomeTest, Torben Nielsen, CEO of Zoom+Care, David Spiro, CEO of MyGoDoc. And why don't we start with our panelists giving us a 2 to 3 minute overview about themselves, their company, and their role. So the first on my screen is Torben. Do you want to start?
Sure. I'm Torben Nielsen, the CEO of Zoom+Care. It's a pleasure to be here today to talk about telehealth. It's an area that we're focusing on very heavily, and looking forward to the conversation. As you can tell, I wasn't born and raised in Kansas City. I'm from Denmark. I've been over here 25 years, and I've been the CEO of Zoom+Care over the past 18 months. Zoom+Care is an on-demand healthcare platform. We serve about 350,000 patients on an annual basis. We have about 60 neighborhood clinics in Oregon and Washington. And with COVID, obviously, we have focused a lot on telehealth and now provide chat with a provider, phone a provider, or video call with a provider. And we can talk a lot more about that, but I'm excited about the opportunities that provides. Zoom+Care is also an on-demand healthcare platform. That's important to realize. It means that 80% of our patients see a provider within 4 hours of scheduling an appointment. We can talk a lot more about that as well. I think that's enough for me. I'll kick it over to one of the other panelists.
Thank you, Torben. Next, I have, sorry, go ahead.
Oh, okay, I can wait.
No, David, go ahead.
Hey, I'm David Spiro. I'm the CEO of MyGoDoc. It's nice to see you all. MyGoDoc is a health access company. We're very, very early stage. We're focusing on primary care doctors and dentists. The most important aspect of medicine is bidirectional communication. And our goal with MyGoDoc is to provide tools and pathways for primary care physicians to better bidirectionally communicate with their families. I am a pediatrician. I'm actually a pediatric ER physician. I started off my career as a young buck doing home visits in Newport, Oregon, paying off my debt, and as a primary care pediatrician. And I know the importance and value of engaging with families and providing what I would call patient-centric care. And really the promise of MyGoDoc is to support and enable and empower primary care physicians to do a better job engaging with their families. My opinion with respect to Torben and others who are in the urgent care space is that urgent care is fine. I think it's known that from an evidence-based standpoint that primary care physicians are the best place to go if you can access them. So MyGoDoc is a brand new, fresh look of around health access in the primary care and dental space, and looking forward to this conversation, and really appreciate the Technology Association of Oregon in inviting me, and honored to be here today. So thank you.
Thank you, David. And next we have Anil.
My name is Anil Kumar, and I am a founder and CEO of RxHomeTest. You can see from the background, it looks a little dark because I'm in India right now. It's close to midnight. And so a little bit about me. I'm originally an engineer by training. I worked with Intel for about 6 years in the silicon manufacturing research and development. And about 3 years ago, I explored more about healthcare and wanted to use my engineering background in healthcare. And I found that the mode of healthcare delivery has so many opportunities. And one of them was to enable patients to do some of those things outside the hospital settings. And one of those modes was around diagnostic testing. So whenever Torben and David talk about telehealth, people mostly think about a doctor viewing them through the camera. But there is so much more that goes in the background. There is a lab test, there is prescription, there is imaging, all those things go in the background. And our business handles the lab testing part of that business. So originally we started around preventative checkup, but when the COVID started, I had a patient in Dallas area who wanted to do an antibody test, and Dallas has one of the highest density of phlebotomists, and I could not find a single phlebotomist to go to this person's home and draw blood and send a sample. So that says how much there's a need for people to collect their own sample in their own setting and use these alternate modes of healthcare delivery. So our business provides this opportunity for people to send their own samples directly to the lab. So we have a network of about a dozen different CLIA labs, and we provide tests from very simple tests as simple as a CRP monitor checkup test to a kidney disease monitoring for critical care patients who need to monitor their sodium, potassium, bun, creatinine on a regular basis. So some of those patients really benefit from this mode because they do not want to be in the same queue as people who need critical care. So we fill that requirement.
Thank you, Anil. And you kind of have led me to my first question for our panel, which is when you're thinking about adopting innovations or implementing new ideas to take your what your companies do and the services they provide beyond the urban cluster, what are some of the things that you have to consider as you're thinking about moving or being more inclusive beyond the urban cluster? And I could either call out panelists or you can jump in with whoever has first thoughts to share.
I can speak first. I think that typically rural practices, and I worked in a rural environment for 5 years, rural practices typically, and the rural market are oftentimes the last bastion of being served from a tech standpoint. And I think there are a number of reasons for that. And with that comes opportunity on multiple levels. When I was working in Newport, Oregon on the coast, it's a very, very poor environment. Sure, there are opportunities in pockets of of wealthy individuals, but the population that I managed was about 80 to 90% Oregon Health Plan Medicaid. So for multiple reasons, those markets are on its surface less attractive, and with that comes opportunity to explore from developing new technologies. So those are my thoughts.
I'll jump in because I actually think it's not so different from how we approach innovation in urban areas. Aditi, I think you start with empathy. You start by focusing on what the patient really needs, and with that, then you run certain innovation shops, and that's what ZoomCare has been doing over the past 15 years, and we've become really good at listening to what the patient actually wants and what they're needing in healthcare, right? Healthcare is really big and complex in the traditional system. We offer something that's real simple, that provides easy access, and that really is tailored or designed around the patient's need. And sometimes those needs are latent, right? We can't see them, but we need to listen and observe to really see what makes a good visit with a provider, right? And I think we've tried over the past 15 years to really stay true to that mission. And that shows in the 14,000 Google reviews that we have, where patients rate us 4.8 out of 5. Because they love the experience that they're getting. And I think that's the same kind of approach that we need to take when we look at the rural setting.
Well, in our case, we tend to claim that we are geography agnostic. Anybody who can receive a mail can actually receive our kits and send their samples to the lab. So with the telehealth advancement in recent times, I think it's been proven that our kind of model actually has substantial room to grow, and the technology is already built. I think there is no doubt about that. The technology exists. We just have to break the barriers to enable our patients to have access to healthcare.
Thank you. Yeah, I think all of you indicated ease of access with telehealth and telemedicine. I also did hear comments around the variable insurance coverage and the type of coverage that might be accessible and available for folks in the more rural setting. So any thoughts on some big pain points that you see? I hear that with telemedicine, access is maybe not as much of a pain point, but any other issues that you've seen in your journeys and how they've been addressed or could be addressed?
Maybe I could say what's different for us in some of the rural settings is, obviously we don't have physical clinics, right? So our patients contact us via telehealth modalities, chat care, phone care, or video care. And sometimes you do need meds or you need labs, right? And so one of the things that we're working really hard on is to get the right partnerships in rural areas where we can easily and seamlessly direct a patient from a virtual channel to a lab setting where they can get their labs done, right? That's one of the, we can't do that when we don't have a physical clinic. So creating some of those partnerships is really key to create a seamless experience for the patient.
My feeling is just like I mentioned in the introduction, as primary care doctors, there's evidence that the best care is done by your primary care physician. Over and over again, studies have shown that primary care physicians, when they're taking care of their families, that care is better than random Dr. X, and it hands down. And there has been no one out there in the market that is focusing on the primary care environment, and how to give those physicians, especially in rural America, tools to access their families. I think that's a significant challenge. Tools, not just telemedicine, well beyond telemedicine. How do we get doctors in the primary care environment into the homes? How do we connect those families to them? How do we create a path for primary care physicians who frankly are struggling financially due to COVID and other pressures that they're seeing? Rapid access to telemedicine is great, but it should be in the right environment. That's my thought.
Yeah, I echo what David said, and I think the two challenges I see are around education, patient education, as well as physician education. I think those are the least appreciated items that we see. So I think those are the challenges that probably in future need to be addressed.
Thank you for that. Yeah, I can say we've certainly had some discussions at OHSU around implementing rapidly advancing telemedicine and educating not just the patient, but also the existing physicians and student physicians and residents around that topic. So I think that triggered another question in my mind, which is, Torben, you mentioned connecting patients with various labs, and David, you kind of indicated primary care providers, but what about when patients need specialists and specialized care, and maybe that leads, them being connected with providers in more urban settings, or even within or going outside of their community. And so what are your thoughts on the ease or lack thereof of interoperability with medical records, with simple things like scheduling systems that can be challenging on their own? And then to layer on that, what Anil was saying, having family members or other providers, care providers who are not physicians, but family members or friends who are helping the patient schedule or take them to appointments. Some of these can happen with telemedicine and some can't. So I guess I'm asking lots of questions in the same question, which is, what can be done, or what are your companies doing to ease those pain points for patients and their families and friends in terms of sharing documents between clinics or online scheduling and e-check-in systems?
I appreciate that. I think that that is a problem. Listen, we live in a fragmented system of healthcare. Everyone can agree that it is incredibly fragmented. Primary care physicians can handle the vast majority of complaints. I mean, when you look at metadata over time, family physicians, pediatricians, internal medicine physicians who are working hard in rural environments can handle the vast majority of cases. What's really interesting is what the patient perception is, and focusing on what the patient experience may be around that and what their value sets are. Patients in rural environments have a general predisposition for thinking that they're not getting the best care, and that the best care is in the cities. The best care is not in Newport, Oregon, but it may be in Portland, Oregon, or Seattle. And how do we work on changing that perception in regard to that one element of the quadruple aim of healthcare? And you're right, it is challenging, and there are aspects of telemedicine that work for perhaps continued care from a specialty standpoint, but sometimes patients have to leave their rural environment and have to physically go to some quaternary care center to actually receive care. You just have to do that, and those are some of the challenges. And it happens less often than you might think. Yes, it does happen, but it happens less often than you think. The primary business of primary care is handling the vast majority of these complaints. And primary care physicians in rural environments become comfortable in handling situations and things that normally suburban primary care doctors turf off to specialists because of the nature of rural healthcare. But there are opportunities, significant opportunities, to improve the way the facilitation of healthcare occurs to specialists and engagement amongst and that bridge between rural and urban care.
Yeah, I think the CMS and the other bodies haven't really done a good job at bridging the gap. And one of the controversial point has been the payment system. About a year ago, you could not get paid for calling your doctor for telehealth. I think about a year ago, when first time you could actually be reimbursed, and that amount was so small that was not even worth the effort. And most of the time you had to go to a federally qualified health center, which is another barrier. You had to go someplace which is literally a hospital and then call your doctor. So it did not make sense at all. But with the change in telehealth paradigm, I think that gap may narrow down, and some of those things may change. But otherwise, a lot is dependent on who pays and how much they pay. And I think Kaiser Permanente is a great example how they have been able to close that gap. It doesn't matter whether you call that a doctor or you physically be there. So it's possible that that gap can be fixed.
Yeah, I would say Zoom+Care is trying to really address the accessibility issue, and that you're talking a little bit about, Aditi, especially to specialists. So we do urgent care, but we also have 10 to 12 specialty lines within the portfolio of services that we offer. And so having same-day access to a mental health provider, or same-day access to internal medicine, or any one of our 10 to 12 specialty lines is truly unique, and is something that we know the sooner you get your particular ailment treated, the better, right, for the patient, and obviously the better for the healthcare system. And so trying to address some of those, in our model is really part of our mission.
Noah asked a question about, can you provide better quality and access? And the answer is yes. Torben, I agree, that there are immediate needs from a mental health standpoint. There are immediate needs for a number of different conditions. Why, when someone has that immediate need, are they not reaching out to their primary care doctor? Why are they not? What is the perceived inability to access a primary care doctor when they need it? And why are patients turning to emergency care or urgent care for that immediate fix or perceived immediate fix for need? I am a pediatric ER physician. It's what I've been doing for the last 20 years. I'm still practicing. And 70 to 80% of the kids I see in the pediatric ER don't need to be there. 70 to 80% of the children who show up in a pediatric ER do not need to be in an emergency medicine setting. And I don't know what the percentage is in urgent care, but it's going to be higher than that. That there doesn't need to be an urgent care. So what is the perceived barrier for patients to not access their primary care doctor? It's really interesting.
Based on some of the research that we have done, we think a lot of it really has to do with accessibility. If it takes 6 weeks to get into your primary care doc, it becomes very hard, right? And that's why we feel instant accessibility, being able to schedule appointments same day. 80% of all our patients, I think I mentioned, see a provider within 4 hours of scheduling that appointment. that shows to me that there's it's an on-demand economy that we are living in, right? Everything is, it used to be back in the day, right? My parents, when they went to the grocery store, they created a long list, right, of things to buy. And then they would go and they would buy for the entire week, right? That used to be how you did grocery shopping or shopping of any kind, right? You created a list, you would go to that particular store and you come back, right? Well, these days, it's on demand. It's right here. I go to Amazon multiple times every day, and my wife and all my friends, they do the same thing because it's on demand. Whenever I have a need, I get my need taken care of because of technology and because of the 21st century experience that we are getting used to. The vast majority of the traditional healthcare system is still in the 20th century, right? Where you write lists and 6 weeks later you see your primary care doc and you have a long list of things that ail you because you know that this is your time with your doctor. Otherwise you need to wait another 6 weeks, right? We are trying to create a much more seamless experience, one that is based on an on-demand 21st century expectation that my primary care doc, my urgent care need, my specialty need is available to me same day. I can engage on this that I use for everything else in healthcare as well. That's what we're trying to do.
And I appreciate that, but there's a difference between, so in Amazon now, you can get things that you can get in Target and Home Depot, and the quality of what you can get on Amazon is the same. The quality of what you get when you get random Dr. X, whether it's Teledoc, Zoom, or whatever, is different than if you're actually accessing your primary care doctor. And I agree that 6 weeks is not okay. And I agree with almost everything you've said, Torben. We are an on-demand society, and the problem is that most primary care doctors have not caught up. They're operating in 1970s technology. I'm going to make a statement that's a fact.
Right.
95% of the way pediatricians, general pediatricians in Portland, Oregon, in November of 2020, now, 95% of the way the clinical engagements occur between primary care pediatricians and their families occurs by calling. Technology that was created in the 1920s, over 100 years ago. When a family wants to make an appointment, they could go online, but oftentimes it's on call. And then when they have a question, they call the triage nurse. And then the triage nurse manages it and they get it back in 2 hours. And then they may get an appointment that day or not. And primary care doctors are wondering why when children and or adults have a sore throat, they go to Zoom+Care to get a strep test. They go to Zoom+Care because it's a beautiful setting, it's quick, it's convenient, they get in and they get their answer. And that works well unless there's a complex problem that occurs and the doctor really doesn't know the family that well. And then there are some challenges there. So I concur with you. And the problem is that we've not, society has not given primary care doctors the tools available to catch up to the teledocs and the Zoom+Care of the world.
Well, it's interesting because we are starting to see a lot of our patients, viewing Zoom+Care as their primary care. Because Zoom+Care is a team-based, setting, right? It's a team-based model. And so it means you can see Zoom+Care as your doctor here in Portland. And let's say you go to Seattle for the weekend and, you start feeling really bad. Well, you can call and engage in a video call with Zoom+Care and they would have all the information available, all your medical records, right? Because it's one system. Or you could go to one of our physical clinics in Seattle and say, you know what, I'm not feeling well. And they would know who you are because your primary care doc is Zoom+Care, right? Across the footprint of 60 clinics, across the footprint of chat care, phone care, using the phone to your point, David, or video care, right? It's all within the same system. And that creates the flexibility that we as consumers, we are so used to in any other setting, right? In the 21st century, It's I want care when I want it, whenever I want it. And that's what we are trying to live into. And it's hard. It's not easily done. But with technology today, we can make it happen.
Thank you for that. Yeah, I think another point that was, that came to my mind as this discussion was ongoing was, I'm thinking about the number of times I've had to call my child's pediatrician or their office at off hours. And unless a person or your family member has a chronic condition, it's usually a first time experience of being in that situation of having to make an appointment outside of your well check visit, whether it's your annual as an adult or a well check visit for a child. And that was certainly, my personal experience in calling the triage nurse. And unless it was something really basic, which I think most non-first time parents probably wouldn't even call the doctor. They would just, I don't know, give the kid Tylenol or something. Very quickly it would go to, you need to go to the ER, and so that, unless it's a very basic issue that could be addressed over the phone, that has been my experience in the couple of times that I've had to call the triage nurse at my son's primary care provider. So changing gears a little bit, what are your thoughts on some of you, David, you've been in medical school, and Torben and Anil, you interact with a lot of physicians and nurses. And, what are your thoughts on some of the educational changes that should be thought of and should be occurring for students that are in training to be nurses or physicians or healthcare providers, to adapt to all of these changes that are occurring, not only from sort of a empathetic view of how do you interact with a diversity of patients, but also from a technological aspect.
Yeah, I appreciate that. What's interesting is that, because I'm still teaching, I'm actually on faculty and in a pediatric ER, so I'm actually engaging with young learners. And I'm actually really encouraged from what I'm seeing. One is that they're learning about systems more than I ever did, systems of healthcare and understanding healthcare utilization. They're obviously way more advanced from a technology standpoint, so they're more facile in managing data and understanding both large and small macro and micro data sets, and they understand those things. I still believe that there's a need to continue to get learners out into the rural environment. As a former rural practitioner, those years working in a rural environment totally made me as a clinician and understanding healthcare and where the challenges are in healthcare. And many medical schools and learning environments send learners out to those environments, but I still think there needs to be a continued push towards understanding systems, understanding where we're driving healthcare in terms of the quadruple aim, and getting on board with figuring out how to defragmentize healthcare, because the fragmentation is why all of us are here, and that creates opportunity, but we're trying to solve problems because of that innate fragmentation of resources.
Well, I view it broadly from three different points of views: the doctor, the technology, and the human touch. So in whether it's rural or urban setting, your doctor remains the same. Most likely there's going to be no change, whether they see you in person or whether they see you via the camera. And the human touch part is very hard to change, because that has to be either really advanced in technology, or your caregiver has to take care of that in rural setting. The third part, I think, is the critical part, which is the technology. Um, with my engineering background, I believe that the next generation of healthcare workforce will have to learn how to utilize the advancement of technology and the data is generating. So, for example, how a patient is sleeping in the night, what is their behavior uh, during the 24-hour period before they complain, um, all those gadgets that they are using at home, all that data slowly will grow, and the next generation of healthcare professionals will have to live with that data, make better sense of that. um, most of the discussion today is that the AI or machine learning will take care of that, but uh, that technology will probably take a while to develop, and at the end of that technology there will still be a human being who will have to interpret and make critical decisions. And I think that's where a lot of new education need to be added, probably in the next decade.
Yeah, I would agree, Anil. I actually think I'm really encouraged. I don't think we need to train or educate the young providers because they're ready. They live on this, right? It's the healthcare industry that needs to, accelerate, right, in utilizing technology. And I agree that there's so much data that we have available that we can, analyze on the back end, that we can create a much better care journey for the patient based on data that we are learning with them over time. And we have a big opportunity there as an industry to do a lot better than what we've been able to do so far.
Thank you for that. So as we develop more technology and innovate, we've seen that a lot of that innovation and technology is built with English speaking and Caucasian people in mind. And, what could be done differently? And I don't mean, be more inclusive, actually what kind of steps could be taken to drive a more equitable structure in engaging with various communities and bringing novel and unique services and technology to a more diverse population?
I would say the if I were to have a simple answer, it is get closer to the people who are involved in those communities, get their feedback, get to know what their problems are, what do they need, and learn from there. I think that would be the starting point. Um, of course, we have shortage of nurses and physicians, and that shortage is actually continuously growing. But the first step to fill that gap would be to reach out to those communities, figure out what their needs are and how those can be fulfilled.
From a technology standpoint, natural language processing and translative abilities are now ubiquitous. So integrating natural language processing and also translative abilities within tech is one way to create equity in that realm.
Thank you for that. Before we dive into, I see that we've got lots of questions coming in. What are your thoughts on any sort of policy changes at a state level to support access to affordable and ubiquitous access to healthcare services and technologies? Any thoughts on that?
One step forward would be the idea, which has been promoted nationally and through various states, is the idea of better access and interoperability access for medical records. So for hospital systems, urgent care systems, primary care environments, to be able to have interoperability access, and FHIR and other technologies are out there that are working towards that. That's certainly one aspect of it that will promote that. I continue to focus on this with my company, which is, and I mentioned this in the opening salvo, the core essence of medicine is bidirectional communication, how physicians and patients engage each other and how physicians engage with each other. And if any steps made from a public health standpoint to improve communication will benefit the family and the families we serve.
I think from where we sit, we're encouraged by some of the changes that CMS are making in terms of reimbursing for telehealth, and we're hoping that focus will continue because telehealth, if you think about it, we can actually treat 70 to 80% of all consultations really could happen in a telehealth setting where you don't need to see a provider in person. And that just creates, a whole lot of new opportunities, I think, in terms of taking care of the patients wherever they live, wherever they are, and whatever time of the day, they have a healthcare need.
Thank you for that. So one question that was received previously was around the topic you just mentioned, Torben, is, increased reimbursement for telemedicine and remote care, and other insurers are also going down that route. And so how do you balance, profitability in the sense of what's reimbursed with doing what's, right for the patient and the family? And, that's probably a constant challenge, and it's not new with telemedicine. It's, I think, a constant occurrence with any kind of innovation in the field of medicine. But any thoughts on that from our panelists, and how do you balance what's covered with what really would benefit society? That's a broad philosophical question. We can just pass on it, which is fine too.
No, I think it's a great question. And obviously it requires us to really rethink, the reimbursement models of healthcare, right? And can we, together with the payers and the patients, get much more towards a value-based payment model, right? Where, we look at whether the patient actually gets better or not over time, right? And I think that's a really hard nut to crack, and that's why we're still discussing it, right? And there are models being tested in various areas of the country, and we are having some interesting conversations with different payers in our markets around a different payment model or structure for caring for the patients that we see. And it's too early to tell, right? But it's where the industry needs to move.
My only comment is what's been missing at times when models are developed is the voice of the patient, the voice of the consumer. And it is changing slowly, and we need to continue to reach out to the patients and the families that we serve and get their voice in the mix philosophically, because they've been the one that's been the minor player in how healthcare is developed over time, as opposed to the payers, as opposed to the providers.
Yeah, I think some of the world's best minds are working on this. So unless there is a legislative change, I don't expect this to be solved anytime soon.
Thank you for that. I'm going to look over some of the questions we've received from our audience. And the first one is from Danny. David, I think you did cover the one from Noah. So I'm going to go to Danny's question. The COVID pandemic has significantly accelerated the adoption of telehealth and the public opinion on telehealth. It seems that there are huge opportunities ahead of us to further adopt telehealth. What are some of the barriers that prevent your company from taking advantage of these opportunities? And can you talk about some of the technology barriers?
I'll just mention two things. Thanks, Danny, for that question. One is we, in general, human beings tend to overcomplicate things. So how do we create technology and systems that simplify the core needs of families and the providers that are serving those families? Number one, we way overcomplicate things. So creating simple approaches, and then we're in the middle of some inflection point. We all know this with COVID and the forced functions of and growth of telemedicine. How do we educate families to understand what those resources are, what the benefits and risks are, and primary care providers as well, and providers in general. I think for certain aspects of the population, there's a fear around technology, there's a fear around telehealth, there's a fear about all sorts of things, some of which are real, some of which are not real. So part of the answer to that, Danny, is education.
So I have a small story to tell. Early on, COVID-19, there was a researcher out of Berkeley who brought 10,000 kits to the community in California when there was such a short supply of test kits. And they asked him to just go away. Nobody wanted to use his kits. And the reason was that they had no way to plug in the data that were coming out of his tests. And that's a huge barrier. People have to build the plumbing of the system so that the data can flow. And we may not appreciate that, but that actually is a huge barrier. So you test people, where does the data go? How does the physician know whether the results were positive or negative? How will the healthcare professional or the community will know who is positive or who is negative? All those plumbing lines of data flow needs to be built, and I think that's a huge technical challenge, and I think that also needs to be solved.
I'll just say, I think it's interesting, we are on track to do about 100,000 telehealth visits by end of this year since COVID started. So there's definitely a strong demand. We still have about 30 to 35% of all our visits, right, are telehealth based. And many of those people are new patients to Zoom+Care, right? They haven't or hadn't engaged with Zoom+Care prior, but now that we have a full suite of telehealth services, we're finding that there's a new segment of patients that really, like the telehealth channel. We think that data is really key. It's very key that the connectivity between the virtual care visit, that is really ported into the physical setting as well, right? Because there will be 20% of whatever happens in a virtual channel that cannot be solved in a virtual channel, right? So you need to go see a particular provider or lab or imaging or whatever. Having the portability of that data becomes really key. And although we've made progress as an industry in terms of interoperability, there's probably still a ways to go. So I think that's one of the technology challenges, or one of the, as you look at the consumer journey, that's one of the areas that we all could focus on more, so it becomes a seamless experience, right?
Thank you. We have a question from Karen. Much of the data is poor quality. Apple Watches received their first FDA approval with only 80% effective at detecting problematic heart sounds. This resulted in many false positive alerts for arrhythmias. Have you received unsubstantiated panic visits from poor quality over-the-counter technology use?
I think a lot of the devices, and if you look at Apple or others, it's still a young industry. We are pushing the envelope. I think some of these technology vendors are really pushing the envelope, and it's still very early. I'm still very optimistic that data from these device manufacturers will help the industry, and obviously will help the patient understand their health better, and will help us care for patients in a much more proactive or maybe even anticipatory manner based on the data that these devices are providing either the patient themselves or the system as a whole. So the patient feels more aligned with their health issues, and maybe even more in control of what options they may have in terms of managing their health. So yes, some of the data may not be good quality data today, but I think we are moving down the right path, and I'm really excited about what this is going to look like, say 5 years from now.
I think it's a common knowledge that a point of care device usually has lower quality of data compared to a FDA approved proper device. For example, doing a PCR test in a CLIA lab versus having a gadget that you take home and do the testing. So in general, that gap is technological, and it is bound to exist the way the technology develops. But over time, those gaps are expected to fill in. So it's not a surprise. I think those are expected as technologies develop.
Thank you for that. I think we have time for just one more question. So here's one. What is your current experience with serving limited English proficiency patients in telehealth platforms?
I think that's a really great question, and it is certainly a challenge. I think from a primary care standpoint, especially in a rural environment, many primary care physicians are challenged with managing patients who are non-English speaking. And it's ubiquitous also in urgent care and in emergency care, and how to manage that. I mentioned this earlier. I think there are standalone technologies available now through various companies that allow for that to help facilitate in terms of translative abilities. And we should all be mindful from an equity standpoint to work and incorporate that in our back-end processes, so we can allow for that kind of access in technology platforms and reduce that barrier, especially as telehealth and health access grows from a digital standpoint.
Great, thank you for that, David. I want to thank Torben, Anil, and David for sharing your thoughts, and also our audience for being here with us today and actively participating. I am going to hand it over back to Riley.
Thank you, everyone, for participating in our third day of Digital Health Week. We really appreciate all of those who engage in the conversation, and thank you, Aditi, Anil, Torben, and David for participating. We thank you for taking your time. We know, especially now, as we're going back into lockdown, that this is a trying time for many people. So we really appreciate you taking time out of your schedules to be a part of this. We invite you all to participate tomorrow. We have Digital Health Day 4. The ONC information blocking rule, is your organization ready, at 9 a.m. And then innovative healthcare delivery and broadband network infrastructure at 11 a.m. So thank you again to everyone for participating, and we look forward to seeing you online at future events.
Have a great day, everyone.
Thank
Have a
you.
great day. Thank you.